In this video, we're going to look at all of the important evidence related to the Lucy Letby case. And this is going to come from experts who have appeared on the channel. So I've put together some of the absolutely key elements of the interviews that I've recorded over the time that I've been running the Lucy Letby Analysis channel. So this is going to begin with an interview with Dr. Steve Watts, in which he talks about some of the very fundamental problems with the police investigation that led to the arrest and ultimate charge of Lucy Letby.
So as I was just mentioning earlier, we're going to discuss confirmation bias with regard to several aspects of this investigation and the case as a whole. So let's firstly discuss confirmation bias with regards in the investigation with regard to investigative decision making.
Yeah, so while serving, particularly after I'd gone away and been exposed to the study of investigative psychology when I took a master's in the mid 1990s, I worked really hard with colleagues in the homicide working group and locally, trying to raise awareness in investigators around the importance of an understanding of psychology and psychological issues as far as they affected the investigative process. In particular, how heuristics and biases can affect decision making in investigations and the way in which we make decisions about the activities and the intent of others, particularly of witnesses and suspects. So heuristics and biases. Heuristics is really sort of a word that describes sort of rules of thumb, shortcuts, mental shortcuts that we have. So, for example, if we're sitting by a campfire at night and we see a movement in the bushes and we think, crikey, that could be a lion, then we'll immediately get up and run away. Far more effective for the preservation of the species that we make a decision that it's a lion very, very quickly. If it's a false positive, it's no problem. All we've done is just run away into the bushes. If we're right and it is a lion, we perhaps have saved our life and saved, the species going forward. So these are naturally occurring phenomenon for all human beings. We are all subject to heuristics and biases in the way that we make decisions every day. We're always looking for patterns. That's why we see faces in clouds. That's why, in our bedroom at night, we might look across to the wardrobe, and a dressing gown may appear as a hooded man, a hooded spectre or whatever. That's the reason these things happen. And so we've got to be aware that we're subject to these cognitive biases as a result of our human development and our evolution.
Absolutely.
I think there's significant evidence of cognitive bias in the Operation Hummingbird investigation because of the way that the investigation began, and I'll talk about that more in a moment, and because of the way in which it appears that lines of inquiry have not been followed to test other hypotheses. So it's important for an investigation, and in particular those leading the investigation, to recognise the dangers inherent in cognitive biases and heuristics, and to ensure that they have in place structures and mechanisms to continually challenge assumptions and decisions about the way they're investigating, the lines of inquiry that they're following, and the inferences and assumptions that they're making. And that can be as simple as having regular meetings where the boss just says, look, are we going down the right road? We think this. Why do we think it? Where's the evidence? What are the alternative suggestions? What are the alternative scenarios that might have arisen that would lead us to this assumption? What other things could have happened that could lead us to this situation? So it's about that recognition, and it's about maintaining hyper awareness, if you like, that whatever decision we come to could be flawed because of the way that we as humans look at it, because of the way that humans are always trying to find patterns, are always trying to um, assemble information, assemble data into coherent narratives. And sometimes there just isn't a coherent narrative. Or sometimes the narrative is actually the correct narrative, is not the one that comes to mind first, and is not the one which is immediately accessible.
Yeah, so I completely agree with you about the pattern issue and how that can be a massive problem. And I think it's very clear that because of this statistical thing, they just, you know, they fastened onto one explanation and then they never considered anything else. That's how it seems to me, and I think that's how it seems to a lot of people that have seen the Operation Hummingbird film. I don't know if you agree with that.
Yeah, I do. I think there is a point that we can identify, and I think it's the meeting on the 15th of May 2017, when Doctors Breary, Holt, and JRAM meet with Detective Chief Superintendent Wenham, and then DI Paul Hughes, who then went on to be Detective Superintendent SIO in relation to Operation Hummingbird. I think it was that point at which they decided that there was evidence that the babies had been killed or unlawfully injured, and that probably Lucy Letby was the person that had done that. And from that point, things moved forward at a pace, and it seems to me that was the hypothesis that was taken forward, and that there was very little challenge to that hypothesis. And in terms of evidence for that, I cite again, the fact that Jane Hutton wasn't engaged, and her alternative view wasn't put into the investigation and wasn't put before the jury. So just sort of staying with the cognitive bias issue at the moment, and how it should be managed. This concept shouldn't be alien to investigators. As I mentioned earlier on, myself and others did a lot of work to try and raise awareness. There are a number of documents. I mentioned already the Murder Investigation Manual in relation to how to set out, how to structure, how to organise investigations, in particular homicide investigations. But in relation to all investigative practice, there's a national document called the Core Investigative Doctrine, issued now by the College of Policing. It's available on the internet, and it sets out the foundational principles of effective, efficient, and ethical investigation at all levels, from the most straightforward to the most difficult and complex. It reinforces the Criminal Procedure and Investigation Act of 1996, which is a piece of legislation which places a statutory duty on investigators, on the police, to conduct an even-handed and balanced investigation following all reasonable lines of inquiry, whether that line of inquiry points towards the suspect, a particular suspect, or whether it points away. So that's something we'll discuss a bit later. The Core Investigative Doctrine, in fact, has a chapter 5, which clearly identifies the dangers associated with psychological biases and how to minimise those effects. So one of the things it says very, very clearly, it introduces a mantra, if you like, which I was very keen to make sure was repeated over and over again to investigators that I work with and who work for me. In order to minimise the negative effects of biases and heuristics, it's important the investigator assumes nothing, believes nothing, and challenges everything. And that relates to every piece of evidence, every theory. So don't just assume because you're talking to somebody, and they're well qualified, that what they're saying is credible. Don't believe somebody because they're passionate and driven. UK policing went through a horrendous period. You'll recall, when people like, the informant Carl, was believed in relation to historical sex abuse issues, which we've now found were complete fabrication on his part. That was because there was a mantra in policing of always believe the victim, which at the time, I raised my head above the parapet and said, that's got to be wrong. Yes, listen to the victim, treat the victim with respect, give the victim support, conduct the investigation. Don't believe anything. That's not the job of an investigator. It's not the job of the police. The job of the police is to gather evidence and put that before the Crown Prosecution Service and eventually before the court. It's of no interest, it's of no import what the police believe. And as I say, everything must be challenged. It's ABC, assume nothing, believe nothing, and challenge everything. I'm not sure that happened in this case.
Once police had began to mount a case against Lucy Letby, one of the most important aspects of this was the shift chart that appeared in court, which was used to suggest that only Lucy Letby could possibly have committed these supposed criminal acts. Some months ago, Professor John O'Quigley, a statistician associated with the University College London and Sorbonne University in Paris, appeared on the channel to discuss some of the many statistical problems with the assertions that were made in court.
So we're going to discuss the statistics in more depth, and I know John is still doing work on this, so not all of which we can discuss, but we're going to discuss everything we can today, and we can always get him back in the future. So we're going to begin this just by asking a very simple question. Why do you think the statistics were so badly flawed in the Lucy Letby case?
Well, for the reasons I guess I just said, they were. It's difficult. I mean, it's like any activity, I suppose. Doesn't matter what the activity is. If you're trying to do it correctly, it always needs care, and that's not just for professional activities. Pretty much any activity, you need to take care, think about it, think about what you're trying to do, and think about what it is we're looking at. That certainly was not the case here. That despite there was no evidence, there's no evidence of a spike. Number one, of course, that's statistical. There is no statistical evidence of a spike, but since then, I came to that conclusion quite some time ago. But since then, of course, we have the report of Shu Lee, and the report that Mark MacDonald submitted to the Criminal Cases Review Commission, the CCRC, and that details very, very carefully all of the incidents that were in the charge sheet against Lucy Letby. Looked at all of them, and so they go way beyond the statistics. They actually say what happened. This is what happened. These are the explanations. And so I think that was one of the first things that was surprising, really, that the pathologists' conclusions were just overwritten. I would think there needs to be some procedure for that. You would imagine, to just override the pathologist's conclusion, say that must be wrong. It's something else. It's a murder. I don't know what the procedure is there, but it does appear that there was nothing required. They just said the pathologist got it wrong, and this is the new explanation. So that is obviously concerning. So I think that those really they got off on the wrong foot right from the word go. I don't. To be honest, I don't really believe that statistics has any major part to play in an investigation like this. I think it should be the conditions at the hospital. It should be various factors which are known to be involved. Statisticians could probably help, but I honestly feel that the role we can play and that we ought to play should be fairly minor. I think at this point it's become rather more important because we have to show that there is no evidence pointing at Lucy Letby. But I think in a normal situation, I think they could say, listen, there's problems here. Let's look at them dispassionately. Let's try and get some idea as to what can be going on and not immediately come to this conclusion that there has to be criminal activity and next to use a very, very dodgy procedure. I will show today, I hope we have time, but I can show just how dodgy the procedure they used is, because actually we can use it to frame anyone we want. Anyone, you just choose a name and I can get the chart for them. It's as easy as that. So it has no real value. But then maybe to go back to an earlier question, if I may, Chris.
Please do.
Let me, because I have with me, by the way, for your listeners, I'm sure that all of them will be anxiously looking forward to your book, as I am. I'm sure they're no less anxious. But in the meantime, for those who are not familiar with the article of Rachel Viv in the New Yorker, I cannot recommend that article too highly. It really, in a relatively short space of pages, she manages to get so much information across there, and then you can come to your own conclusions. But it's a very, very well written piece. So I have it with me, and I'll just quote a couple of things just to try and underline the importance of that chart, and because it comes across here. And right early on in her article, she says, am I reading the right thing? Sorry.
Okay.
Oh, yes. It says, no one ever saw Letby harming a child, and the coroner did not find foul play in any of the deaths. Of course, that we know. And then she says, well, the case then gathered force. Those are her words. It gathered force on the basis of a single diagram shared by the police, which circulated widely in the media. That is the chart, And Nick Johnson told the jury in his opening statement, if you look at the chart overall, the picture is, we suggest, self-evidently obvious. It's a process of elimination. And I'll just, a couple of things at the very end of this paper here, where she picks up Johnson's examination, cross-examination or interrogation, I don't know what you call it, of Lucy on the stand. And this is what he says. Do you agree that if certain children were attacked, then unless there was more than one person attacking them, you have to be the attacker? That's what he said. Where's he getting that from? He's getting that from the chart. And then he continued, if they were actually attacked by someone, then the shift pattern gives us the answer as to who the attacker was, doesn't it? Well, Lucy, of course, does not agree. And then he insists, he doesn't drop it. So let's say if baby 5, 8, 10, and 12 were all attacked, if the jury looked at the medical evidence and they were all attacked by someone, and you are the only common feature, it would have to be, wouldn't it, that you are the attacker. So that chart, they can say whatever they like. I know the main prosecution expert witness insisted that statistics was irrelevant. They didn't insist that at the time, of course. That was afterwards. But if the statistics are irrelevant, I'd like to know what is relevant, because even if we accept that there was some evidence of poisoning via insulin, or that babies may have died because of air embolism, either in the stomach or in the bloodstream, then who? It still does not point to anything. It could be anybody. Nothing points at Lucy. The only thing that points at Lucy is the chart. So the chart is it's absolutely crucial. In my opinion, it's the whole thing, not just a small part. It's really everything. It's the essential part of the case.
Aside from these general problems, Professor O'Quigley also went into some detail regarding the shift chart, explaining, as we'll see in the next clip, that it would be possible to construct a similar chart to the one that was shown in court for many of the nurses that worked at the counters of Chester.
So this is the chart we get. Now, does this look any less compelling than the chart we started with?
No, it looks exactly the same.
It looks, well, it isn't exactly the same.
Well, it looks exactly the same in terms of there's one omnipresent nurse, isn't there?
Yeah, it's nurse 30. It's a different nurse.
Yeah.
Lucy Letby is nurse 23. This is nurse 34. It's using the same techniques. It's using this for every nurse involved there. I use the rates, just how often, though, apart from nurse 23, of course, but everyone, it had their presence. The rate was 1 divided by 25, 2 divided by 25. We simulate on the basis of that rate. We obtain that. And then we just iterate the charts in exactly the same way that they did. Only this time, I had a gut feeling, just like they did, by the way. They referred to that many times, their gut feeling. So even in the report of the Royal College of Pediatrics and Child Health, they said that the consultants pointing to nurse Lucy Letby was just based on gut feelings, and they were right. They were just based on gut feelings, and they themselves agreed they had no evidence. It was just gut feelings. So here, my gut feelings point to nurse 34. Now, if I was running this investigation and I had those gut feelings, and don't forget that the consultants worked with the police all the way through this. So this is what I would obtain. I would obtain nurse 34. I would show this to the jury and say, listen, I think it's, as Nick Johnson said, it's obvious, self-evident. It's nurse 34.
Yeah. And that could be done for other nurses as well, couldn't it?
Yes and no. Actually, yes. Well, it's interesting. You'll see something. You make a good point, Chris. Let me close that down. See if I can find. I did have another chart. Here we go. Okay. This is nurse 16. So I did do a random number generator, and this time I came up with nurse 16. So this is, oh, no, I don't, what am I doing here? Annually, I'm doing something wrong. Okay. Sharing the screen. Okay. Is that showing up?
Yes.
So this is nurse 16. Now, I do exactly the same process for nurse 16, but the only thing was the rate of presence for nurse 16 was small, very small. So even if I'm looking at the pool, the unused pool of suspicious events, I can never quite find enough. Actually, in the other case, I didn't quite find enough either. I had 24, but it looks almost as good. But with nurse 16, I couldn't go beyond 10. That used up everything, you know. It still looks impressive, but it doesn't look anything like as impressive as having 25. But so yes, your point is I can frame anyone I want, anybody I want. Some will look better than others. And of course, the ones that look the best are going to be the nurses who work the most. So working a lot and working more than everyone else is very hazardous in an environment like a neonatal unit. I mean, I know I shouldn't say such a thing, but if I had a daughter working in an environment like that, I would say don't. It's just too, certainly in England or actually anywhere, I'd say it's just too dangerous.
This was serious in and of itself, and obviously these were major mistakes made by the police in the case that they put together, which has resulted in the jury being seriously misled. However, they had the opportunity to avoid this. They had previously commissioned statistical work from Professor Jane Hutton of Warwick University, but as Professor Hutton explained to me, this didn't go ahead as planned.
So I had an email on the 22nd of March 2018 saying that my name had been given, they'd been searching for somebody, my name had come up for the medico-legal side of things, and that they were investigating a spike in the number of babies collapsing and dying in a neonatal unit at a hospital, and that they'd collected substantial material, and what they wanted was somebody to help them understand and assess the chances of sheer coincidence, and possibly with comparisons to other universities. other hospitals. So, I responded and arranged to have a conversation, as well as asking what information was available. And, very early on, I said, the correct approach is very well established, been established since 1980, of how you investigate these things. And I explained what the correct approach was and what the correct question to ask was, which is, if you have a cluster of events, what are the possible explanations and which is the most likely? So yes, obviously you have to go through procedures, setting up contracts, both in terms of fees and in terms of confidentiality and non-disclosure. So at that stage, I wasn't even seeing anything. And the first thing was simply seeing on a screen the numbers of deaths. Essentially, those are the figures that Professor Sir David Spiegelhalter discussed in his submission to Thirlwell. And he got exactly the same answer as I did, in terms of, yes, there was a spike in numbers, and yes, you needed to investigate. But of course, that's what you need to do. You need to investigate. You don't assume we've had a spike, therefore there must be a murderer. No. Funnily enough, I think it was about 1990 when I was at Liverpool. I was asked to give a talk to a medical group precisely about small numbers and how they can affect things. And in that, I used an example that if you were looking at, children's unit, and one year you'd had 3 deaths, and the next year you'd had 8 deaths, that one of the first things you needed to do was to look into it. And if you found that, there'd been a sudden increase in vitro fertilization, and you'd had, in the second year, you'd had quintuplets and then triplets, you have a difficult question, because they're not just simply 8 deaths. If we're thinking about how frequently are these are 2 pregnancies and 8 deaths, but that's not the same as 8 singleton deaths. So it isn't a question of saying there's a high rate, somebody must be to blame. There's a high rate, what is happening? And so to be asked, can you come up with a figure like 1 in a million that there's one particular person present, is completely the wrong question. And of course, it's an echo of the Sally Clark mistake that was made by a retired paediatrician in the late 90s. So yes, we set up contracts, we had discussions, and I was fairly busy with quite a few things. So I was rather surprised that we kept not getting the information. And I followed it up occasionally, but I certainly didn't pursue it actively. I didn't have the capacity. I was quite surprised that the police arrested Letby at a stage when, as far as I knew, they couldn't possibly have had valid evidence against her.
There were a multitude of problems with the care of infants at the Countess of Chester Hospital on the neonatal unit in the 2015 to 2016 indictment period. Indeed, there are far too many problems to possibly document them in just one video. However, one of the most prominent was the presence of sewage on the unit, which certainly played a role in the presence of infection. This was discussed by Professor David Livermore when I interviewed him approximately a year ago, and at that time Professor Livermore outlined to me the issues related to Pseudomonas aeruginosa, which was one of the bacterium present on the unit.
So we're going to talk about your area of expertise now, which is the biological field. So I want to... You've already given a bit of your opinion on the presence of Pseudomonas on this neonatal ward and the significance of this, but could you firstly tell us about the bacteria itself?
Sure, I've had a relationship with Pseudomonas since starting to do a PhD on antibiotic resistance in Pseudomonas, 45 years ago now. So I've a good deal of my life has involved Pseudomonas. It's a bug which naturally lives in water. It does, historically, it did nobody any great harm whatsoever. As late as the First World War, physicians were quite happy if a wound got Pseudomonas, because if Pseudomonas got in the wound, then the bacteria that killed a wounded squaddy quickly, streptococci, wouldn't get in. But we now live in a world where medicine has gone on and we have sick and vulnerable individuals who are prone to be colonized and infected by Pseudomonas. And it's a resilient sort of bug used to living in natural environments. It can get into virtually any body site, and in the vulnerable, and that includes very small infants, it can cause severe infection, and because it's antibiotic resistant, can be difficult to treat. Now, its other trick as a bug that lives in water is that it likes human-built water systems. So it gets into a hospital tap, it can grow back up the pipes, and it is extremely difficult to get rid of it once it's done that, because it forms what's called a biofilm, which is a sort of structured community of bacteria growing back up the pipe. And if you search the literature, you will find descriptions of what happened at St George's Hospital in London, where they had a major problem with Pseudomonas in the pipework, which then this same strain of Pseudomonas, which was particularly antibiotic resistant, popped up all over the hospital. And that was because it was in the water system. Ultimately, they did a lot to the water system. They got rid of the problem, and they did their utmost to manage it. But it does show what a problem this bug can be. And to illustrate what it can do to small infants, the best example would be Belfast, where one of the maternity hospitals there, must be about 10, 12 years ago, they had the death of 3 infants who had been washed with tap water. And they're obviously very vulnerable infants. These were not normal, healthy babies, but we're talking the same sort of category that Chester had. And the water was contaminated with Pseudomonas. And a lot of thought after that went into surveillance for Pseudomonas and ways to try to manage the Pseudomonas problems where they arose. And you see some of that reflected in Chester. They had identified that at least one, and as I've subsequently heard, 2 taps within this neonatal unit were colonized with Pseudomonas. On at least one, and probably both of the taps, they had filtration systems that were supposed to take out the Pseudomonas. But to quote Sarah Knapton's article from the Telegraph, the filters kept falling off. So you have there very vulnerable infants in a not well managed unit, which has a water supply which is contaminated. They know there's contamination of the taps, but they're struggling to eradicate the bacteria from this system. So that's one of their microbiological hazards. I've not seen anything to say that Pseudomonas was actually isolated from any of these babies, but it can be extremely difficult to get a good sample of blood or sputum or whatever from a very small infant. The microbiology can be difficult. So Pseudomonas is in there as a plausible cause of infection because we know it was contaminating the water system, and we know that contaminated water systems, or Pseudomonas contaminated water systems, are a hazard for such tiny infants.
I discussed a variety of issues with Professor Livermore, but I'm going to limit myself to just 2 of these in this video. The second thing that I want to get into that we chatted about just over a year ago was the endemic sepsis which was apparent on the neonatal unit.
we're going to discuss sepsis now, but before I do that, I'll just mention to you that the third insulin case, which is child Y, is described as, that's got sepsis all over the notes of the third.
Yeah, well, that one wasn't on the indictment, but it's
Yeah.
and it's one of the insulin cases. Definitely, it's L. I think it was on antibiotics, and so that implies somebody thought there was infection there. And as I read F definitely was, not L, but L also possibly was. One of Sarah Knapton's articles, I believe, indicated both insulin babies were on antibiotics, but F definitely was.
Yeah. And then I should mention as well that the non-indictment infants all had signs of infection as well. Sometimes that was cited as the cause of death, but they just weren't in the indictment, of course. So, but we'll talk now about sepsis. So could you discuss the relationship between Pseudomonas and sepsis?
Well, Pseudomonas sepsis by definition is the combination of the infection and the body's response to infection. The fever, the sweats, the series of biomarkers, C-reactive protein, etc., that go up the migration of white blood cells. And the cytokine response. Sepsis is the syndrome. Infection is the cause of the syndrome. And Pseudomonas is one of many bacteria that can cause sepsis in the vulnerable, which, the very old, somebody who's got a cancer, somebody who's had major surgery, or as here, very small, premature, vulnerable infants are at risk from Pseudomonas. Somebody in good health is not at much risk from Pseudomonas. I mean, look, in my early days of doing laboratory experiments somewhat dangerously, once got a tremendous mouthful of Pseudomonas aeruginosa from a result of mouth pipetting it, which was still acceptable in those days, but would now be very deeply frowned on, and rightly so from a health and safety perspective. And I lived to tell the tale. I drank some very strong coffee afterwards, get rid of the taste. That was perfectly all right. But I was in my 20s then, and in the best of possible health. Somebody who's old and vulnerable, being exposed to a lot of Pseudomonas is at risk, or as here, a small infant, and sepsis can ensue. And it's because it's so antibiotic resistant, there is a bigger likelihood that whatever first line best guess antibiotics are given fail to cover it.
The central and most distinct component of the allegations made in court was the notion that Lucy Letby deliberately utilised air in order to destabilise and even kill babies. This air embolism theory was discussed with me by the highly experienced Dr. Michael Fox, who had some very unusual and niche experience which made him a particularly authoritative voice on this topic. It should be said that several other medics on the channel have also expressed disdain for the evidence presented in court, but Dr. Fox went into quite some detail regarding the air embolism allegations.
So let's talk about, you mentioned the post-mortem process, and there are documents in the thermal inquiry which indicate there's no frothy blood in the ventricle of the heart, which is a key indicator of air embolism. It's a diagnostic indicator. So could you give me your opinion on that, please?
Well, that shoots, as far as I can see, that shoots down that theory, because unless it was frothy blood in the heart, I can't see that it would have that the air embolism that was supposed to have happened would have caused these babies to perish, because it certainly wouldn't have got into the arterial circulation, where you don't need very much to do some damage. So, uh, yeah, that I think that demolishes that.
And it is in that document where they're reflecting at post-mortem, they say there could be a small one, but I mean this doesn't nothing to be concerned about. It's just that frothy blood will happen if there is a large air embolism or large bubble, large amount of air, however you want to describe it. And it's just, it's very evidently not present from someone who has examined the infants, where of course Dr. Evans didn't do that. So yeah, I mean, I would say that.
As I recall from medical school days, that was how they used to dispatch laboratory rabbits after been doing whatever they were doing to them. Inject air into find a vein in the ear, and inject a quantity of air, and that was the method of killing them. To see them off humanely, was to inject air, sufficient quantity of air, which would froth up in the heart, and that's that essentially stop the circulation on the right side of the heart. But then if it stopped it there, it's not going to get through to the left side of the heart. So yeah, that's the end of that. Excuse me.
Yeah. So another thing that you mentioned to me is that an air embolism could occur accidentally in child P due to a pneumothorax. Could you explain this, please?
Well, yeah, I mean, I've not read any of the documents, but when I think it was when you were talking to Martyn Pitman, he said that child P had a pneumothorax. So yeah, that could be a potential source of fatal air embolism. If the lung got damaged, in whatever process caused the pneumothorax. And that is the principle of the air embolism that, that arises, as described in the Dr. Shuli's paper, the Lee and Tanswell paper, where they're describing, I think it'd be ventilated infants, where the ventilating, either the pressure's too high or the lungs are too weak to cope with a positive pressure ventilation. The lung gets damaged, air leaks into the pulmonary circulation through the left side of the heart, and if it gets into the cerebral circulation, that's bad news. So if there's evidence of lung damage caused by enthusiastic ventilation, then that's which could cause a pneumothorax, and that could also have caused a gas embolism arising from the lungs, which is what Professor Shuli is describing in that paper.
Yeah, so there are also in this paper, it's noted that it's not even describing the right type of air embolism, and it's been completely misused. So how do you feel about that?
Oh well, that was what's described in the Lee and Tanswell paper is perfectly valid, but it's nothing to do with what Evans is describing. It's completely separate from giving an intravenous injection of air, because here the air is arising from the lungs. That was the other thing I wondered. I did wonder if she's caused air embolism. Maybe she's fiddled with the ventilator settings, but then people would have noticed that.
Of course, just to add, it's because it's not an allegation in the court case. So.
No, it wasn't. But that was what I thought. If she has caused air embolism, maybe that's how she did it, by messing around with the ventilator.
And is it on that basis? Is it likely, or at least possible, that we hear a lot in these cases? I mean, when I'm hearing about this is way outside of my area of knowledge, expertise, understanding. But clearly, there's been a lot of ventilation used in this court in these tranche of infants, and there are allegations or assertions that they overventilate several of them, I believe, and used excessively high pressure settings in some infants as well. So can that be a sort? So that could be a source of air being present, couldn't it?
Oh, it could certainly could be. Yes, yes. The you see, in the diving medicine world, we were very, we were very sort of a bit anti pushing air into the lungs under positive pressure. After I left, shortly before I left the Navy, I think I was starting to go around in ever decreasing circles, but they sent me on an aviation medicine course at Farnborough with the RAF, and where I learnt about aviation medicine, and then the Navy started getting smaller, and I thought, well, my prospects here are, probably not going to go very far. And I went back to doing the medico-legal job, which this is 1994, and I was supposed to go to a naval air station, Yeovilton, but instead I went back to London to do the medico-legal job, which I'd previously done in 1989. I thought, well, the writing's on the wall. They were offering redundancy, so I applied for redundancy and got myself out, and went to Australia for a couple of years. Did a little bit with Flying Doctor there, then came back and I saw an advert for people wanted doing aviation medicine in Saudi Arabia with British Aerospace. So I phoned them up and they said, when can you start? So and I spent 15 years there. So I had 15 years in the Navy and 15 years in Saudi doing aviation medicine. Now in aviation medicine, here we do use positive pressure ventilation when in fighter aircraft, you may use pressure breathing. If not routine, well, there are two instances where you may use pressure breathing. One is if there's a decompression at very high altitude, and I'm talking over 40,000 feet. So some high performance aircraft will operate at that sort of altitude. So if the canopy fails, there's a pressure failure, breathing 100% oxygen at that sort of altitude will not protect them. They need oxygen, 100% oxygen, but under increased pressure. And depending on the altitude, that may be up to 40 millimeters of mercury positive pressure being forced into the lungs. We used to do that to people. We had an altitude chamber there at Dharan, and we used to give them pressure breathing training at 43,000 feet, where we're given explosive decompression, and the pressure breathing would come on, and it's sort of like the reverse of what you normally do, because the air is just forced into your lungs. You get blown up quite vigorously, and then you have to breathe out quite hard to push the air out. And as soon as you relax, you get another blast of air coming into your lungs. So that's one instance. And the other instance is you can use it for protection against G-forces. And I believe the Typhoon does use that, and you use the oxygen regulator in the aircraft under the right levels of G will give positive pressure breathing into the chest to increase the pressure in the chest to make sure blood keeps going up into the brain, so that they don't go unconscious. So I won't go off too much about that, but yeah, we do use it. It was used it is used in G protection. And in fact, we did get a centrifuge there while I was there, and I had the pleasure of commissioning a brand new centrifuge. And that's a sort of ultimate big boy's toy. We used to put the cadets through this, and with the right levels of G, used to try and make at least one member of the group unconscious, so they can see that this really does matter. If they don't pay attention and if they don't try and protect themselves, the G can get them and it will kill them, because they'll go unconscious while flying. That's not a smart thing to do. As far as I know, it's only the Typhoon had the pressure breathing for G. Other aircraft, for G protection, they had to you had the G trousers, which give you a bit of protection, but also straining was the important thing to go. Try and increase the intrathoracic pressure to increase the blood pressure, force blood up into the head. But yeah, we use pressure breathing. So I've gone on a bit then.
Okay.
So, oh, sorry, yeah. So pushing air into lungs can be done, and the maximum pressure we would use about 40 millimeters of mercury pressure. I'm not sure what settings they use on ventilators for neonates. See, neonates can, I understand they can have premature, can have very stiff lungs. So I'm not sure what pressures they may use to try and overcome that.
In this final section of the video, we're going to go into some details regarding some of the specific infants in the court case. This begins with paediatrician and now neonatologist Dr. Ellen Storm discussing some of the issues related to child A.
So when he talked about the long line, he's already gone to C. He's gone to C. He's pulled out the long line, and then he's gone back to A, airway and breathing, and put in the tube. And the problem that we have here is that what they're saying is, and it's not what Dr. Jairam has written, but Dr. Jairam's timings are not quite clear. So the neonatal review is a bit clearer on this, that the heart rate decreased and they started chest compressions after the tube was put in. There's absolutely nothing there to say that they took the tube out and went back to mask ventilation because this baby subsequently collapsed. Now, a baby that collapses in the minute after they've been intubated is collapsing because they've been intubated until proven otherwise. As in, that is a iatrogenic tube problem, even if you think that you've got it in the right place. And I say this as someone who has stood there, having intubated the esophagus, saying to the nurses, no, I saw it go in. And they said, take it out, because they were doing their job. And that was the right thing to do to me as a trainee at the time, because that baby was desaturating. Take it out, put the face mask back on, start again. So I learnt that lesson. And that was back in the days before we had the video laryngoscope.
Yeah.
So the right thing to do if you intubate a baby and that baby starts to become more bradycardic and desaturate further is to take your tube out. And that hasn't happened here, or at least it's not documented as having happened here. And when Dr. Jairam comes in 5 minutes later at 2033, sorry. Right, so he then, go back to that one. I'm just going to find the right bit so I can actually say
No problem.
the right thing.
That's fine. Take your time.
Yeah. So he says at 2026, sudden apneic spell, initially heart rate and good sats. Bag valve mask ventilation commenced via, but not by, Dr. Harkness. Good chest movement and air entry, but heart rate dropped and lost output. Legs noted to look very white and pale before cardiac arrest. CPR commenced, resus progressed as documented by Dr. Harkness and Wood. resus drugs given by UVC, which was in the wrong place in the liver, but never mind, we're not talking about that right now. So I haven't seen notes written by Dr. Harkness or Dr. Wood. I don't know if those are in the public domain. If they are, I haven't seen them as yet.
Sure.
I would love to see them. It would help a huge amount for us to understand what has gone on in this critical 5-minute period of the end of this baby's life. Okay. So they then go on. They don't remove the tube. So the question we then have to ask, because what has been said is, yes, they confirmed placement with capnography, and they saw chest movement, and they heard air entry. Good chest movement and air entry, but heart rate dropped and lost output. So I've also been involved in a case relatively recently, because I had to be a witness in the coroner's court for this case, where a junior doctor was resuscitating a baby that I was called to continue that resuscitation, and they believed that they saw chest movement. So we are taught by the newborn life support course team people to look for chest movement. And that junior doctor reported that he saw chest movement when there was absolutely no way that he could have seen chest movement in that baby, and there was definitely no chest movement. But there's a particular problem with the algorithm, which is that it tells you, this is to do with how you resuscitate newborn babies at birth, actually, but it tells you to do 2 rounds of inflation breaths, and then once you have seen chest movement, you go on to do what's called ventilation breaths. And it's not very clear what you do if you don't see chest movement. So after you do your 2 rounds of inflation breaths, you go on to your ventilation breaths. And if your baby, if their heart rate goes below 60, that's when we would start CPR. So babies, they don't have cardiac arrests in the same way as adults, because their problem is usually respiratory, not cardiac. Their hearts don't just suddenly stop. Their hearts get slower and slower and slower over quite a period of time. Yeah. Because the heart is usually fine most of the time. So most babies who have CPR have a primary respiratory problem. And the problem is oxygenation. And they become bradycardic because they're not getting enough oxygen going to the heart.
Okay.
Yeah. So in the NLS algorithm, it tells our junior doctors, most of whom at the moment they go to deliveries and they're not trained to intubate. A lot of the doctors and also the midwives who go to deliveries and resuscitate babies, they're not trained to intubate. That only really happens if you're a paediatric trainee and once you get to become a registrar. So if you've done your inflation breaths or you've done your ventilation breaths and you don't know how to intubate, it's not very clear what you do next, other than shout for help and hope that your senior who does know how to intubate can get there quickly. And psychologically, what people do when they don't know what to do next is they move on to the next bit of the algorithm anyway.
Yes.
Don't know if that makes sense.
Yeah.
But they've done their inflation breaths and the baby's not responding. So they do another set of inflation breaths and the baby's not responding. And I've had another case recently, actually, where they did a 3rd set of inflation breaths, which is not on the algorithm because the baby was not responding. And then they're sort of a bit stuck because they don't really know what to do because the baby's not responding and they've done their inflation breaths and that now they don't have the skills to actually escalate that, and deal with that problem. So what they do is they move on down the algorithm. And that means that they start doing CPR when they haven't dealt with the airway. So ABC means that you do deal with your airway first, then you deal with your breathing, and then you deal with your circulation. And your circulation is your CPR. In babies, you shouldn't start CPR until you're absolutely certain that you've got a patent airway and you've got air going in and out of your lungs. And if you have got that, and then you can start your CPR. Now, the problem with the unrecognized esophageal intubation is that people hear, they listen with their stethoscope, and what they actually hear is the air that they're putting in and out of the esophagus or in and out of the stomach. So they hear that, yeah, and they mistake it for air entry. And a 31 plus 2 week baby is very, very tiny. And so the sound of the air going in and out of the stomach is all over the body. Like, you just hear it wherever you put your stethoscope, because the stethoscope covers half of the chest anyway. You hear, and people hear the noise and they mistake it. And in that, so then we have what we call human factors error. There's been a lot of talk about human factors error, more recent years, I think, that people who are very stressed in these situations, and perhaps a little bit out of their depth as well, they make human factors errors. And thinking that you can see chest rise when there is quite clearly no chest rise is one of those.
Yes.
And if you don't know what to do next, the only thing you can do next, and you're really stressed and all that adrenaline is going around your system, and people say they can hear chest rise, they can hear air entry, and they can see chest rise so that they can move on to CPR. They move on to the next stage because the baby's heart rate is dropping and they don't know what to do. They're out of their depth, really.
Yeah.
Does that make sense?
It does.
So it's really sad, but there is clear precedent for this happening not just once but multiple times, both in babies and in adults. And it is why we brought in capnography and why we've brought in the glide scopes, the video laryngoscopes, because of exactly this tragedy and wanting to stop it from happening. Now, let's say that this baby did get intubated into the esophagus, how would we know? Because we never did a chest x-ray during life after that point in time. Like when we do an intubation and we think we're in the right place and everything's going well and the baby's put on the ventilator, and then we get a chest x-ray, right, to check the position. We look at the level where it is in the trachea. That didn't happen. So the next x-ray that we got was the x-ray post-mortem. Now, I have not seen the post-mortem x-ray. I believe it was a single AP view. And I have read Dr. Arthur's testimony, which does not make any reference to the presence or absence of an endotracheal tube in the trachea. I'd be very happy if someone wants to correct me on that, and there is something somewhere to that effect. But from what I have seen, there is nothing that confirms whether that trachea was or was not still in place. Now, there's two problems here. One is the esophagus lies directly behind the trachea. So if you take an x-ray, what we call an AP x-ray, an x-ray directly through, baby's lying flat, there's a x-ray, sheet behind, it's lying on the x-ray sheet, and then you take the x-ray directly through that direction. Yeah. Even if you saw a tracheal tube here, you wouldn't be able to confirm whether that tracheal tube was in the trachea or the esophagus. The only way you could do that would be to take an AP and a lateral. So you'd have to take a lateral x-ray sideways, and I'm almost certain they won't have done that. But I haven't seen anything to say that they did do that, and I haven't seen anything that confirms that the trachea was there. The only other way you would be able to tell is if somebody at the post-mortem, the person doing the post-mortem, actually put a laryngoscope in before they took the endotracheal tube out and looked at the position to see whether it was going through the cords. I don't know. I think it's unlikely that they would have done that. I've not seen anything saying whether that was done or not. Usually when a baby dies and they've been intubated, you should leave the tube in situ for the post-mortem. So the tube should have been there when the baby goes to post-mortem. But what happened next, we have no idea. So unless the post-mortem report clearly states that they have checked the position of the endotracheal tube in vivo by looking at it, and it was definitely through the cords into the trachea and not into the esophagus, unless that was documented at the time of post-mortem, I think we would have to conclude that we do not know the answer to this question.
Okay.
And if they didn't do a lateral x-ray, you wouldn't be able to say for sure whether that endotracheal tube was in the trachea or in the esophagus.
Okay.
Does that clarify the nature of the problem that I've been lying awake at night thinking about recently?
Yeah, absolutely. And you're not the first person to say to me I've been lying awake at night worrying about this case. I won't mention the name of the other person who has lost a lot of sleep.
Esteemed neonatologist Professor Colin Morley also appeared on the channel to discuss the massive problems with the prosecution case in relation to child C.
So you touched upon the signs of bowel obstruction in child C, but could you just go over those again, please?
Yeah, well, thank you. Bowel obstruction. Okay, right at the beginning, baby starts vomiting green bile, worrying sign. They get abdominal distension, but it depends whether the obstruction is high. Let's say the obstruction is in the duodenum, then there's no gas in the bowel if there's an obstruction there. And if the obstruction is right low down in the rectum, then you can get a lot of gas in the bowel that isn't able to move on. So distension, bilious vomiting and distension, and of course vomiting anyway, because the bowels aren't working. So yeah, I think there's a whole number of causes that we all know about, and in this case, you know, the baby. Of course, the other sign of obstruction is they don't pass the meconium or pass a stool. So the stuff isn't getting through. And there's a number of causes of that. It might just be a stenosis, a blockage in the bowel. It might be that it's Hirschsprung's disease, where the nerves in the rectum don't work properly. But one of the things that's been published in the last few years, it's not brand new, is that there can be, so the nerves operating the lower bowel just aren't working very well. And it's a sort of functional thing. It's not an anatomical thing. So, yeah, I think, but we won't know in this case. I mean, they certainly did biopsy at post-mortem and showed that there was no Hirschsprung's disease, which they would see on the specimens that they'd looked. But there was no doubt she had bile stain vomiting. She didn't pass meconium and had distension.
Okay, that's great. I'm just going to put my dog out. She's been really annoying.
That's all right.
Kate, either come here or go out. Come here. Here. Hey, there we go.
I've seen him before on your videos.
If I'm talking and I'm not stroking her, she just cries. But then if I put her out, she's like, "Oh, I'm not in the same room as you now." It's not so, but she lies away from me, so I can't reach her. So I just had to move her. So sorry about that, Minor.
No, that's all right.
Yeah, so that's absolutely great. So a very simple question now. Do you think the hospital did an adequate job of managing and treating child C?
No, simply, I mean, they got they didn't get the diagnosis right. They certainly didn't get, I mean, a child with bilious vomiting who's got distension, no bowel motion, no meconium pus, should have been referred to the surgeons at Alderhay and had proper investigations. Instead, at Chester, they kept saying, oh, well, you know, it's all right, it'll be all right tomorrow, sort of thing. And of course, it wasn't.
Yeah, absolutely.
So did they look after it properly? No, I think they were very I don't think they really knew what they were dealing with. They wouldn't, the ordinary pediatrician wouldn't see babies with bowel obstruction more than, you know, once every couple of 3 years, I would think. And particularly a very premature baby, that just adds to the difficulty. And often, as far as I can read from the notes, they'd ring up the Alderhay and the Alderhay would say, we're jolly busy, we haven't got any room, just keep going, you're doing a good job.
Yeah.
Next, I have a couple of clips of Michele Worden, who has been a guest on the channel several times. Michele is a neonatal nurse who was an advanced neonatal nurse practitioner at the County Chester Hospital for many years. In this first clip, Michele discusses child D, which is an infant that's been particularly highlighted to me as receiving extremely poor care during the period that it was sadly resident on the neonatal unit at the County Chester Hospital.
So we'll go on to baby D. So it's background of baby D. Mother told the trial that she and her husband had to ask Letby to leave them alone with their daughter during their first visit to see her on the neonatal unit. She described Letby, who went on to murder baby D with the injection of air into the bloodstream hours later, as hovering around their daughter's cot, watching them and making her feel uneasy. She could have just left us to it, but she stuck around, baby D's mother said. She was watching and looking over to us, and I asked my husband, can you tell her to go away or give us some privacy? Baby D's mother later told the public inquiry, I don't know why she stood out. I didn't catch her doing anything in particular. I just remember thinking, this person does not belong in this situation. Why is she here? She also described Letby watching the couple crumbling during attempts to resuscitate their daughter. I could see Dr. Brunton holding her baby D and trying to save her. There was a lot of people. One that was doing nothing useful, that was Lucy Letby, and she was just looking at us crumbling and crying. And Dr. Brunton was trying to save my daughter, and he was trying really hard. So just, I mean, I could comment on this, but what do you think, Michele?
Well, this baby was obviously deteriorating. Now, was Lucy looking at this baby as if to say, I'm going to have to intervene here because this baby is deteriorating and nobody else was picking up on that? As a neonatal nurse, she has a duty to keep an eye on that baby. You know, that baby had just been admitted, was obviously sick. So I don't understand why the parents are saying we wanted to be left alone, because this baby was in a neonatal unit. You don't leave babies alone in a neonatal unit because of the risk of collapse. Again, in court, it was said that these babies suddenly collapsed and suddenly, you know, had unexplained desaturations and bradycardias. But to me, having read a lot of documentation now, you could see that, you know, these babies obviously had problems antenatally, and we've discussed the lack of maternity input into this trial. But as a neonatal nurse, if I've got a newly admitted baby or a baby that I think doesn't look quite right, maybe is going to deteriorate, I'm not going to leave those parents either. I'm going to hover because you need to be there. You don't leave them. So I think, again, this has all been taken out of context. These parents, we know, I mean, there was clear medical negligence on the maternity side with this mother. She had prolonged rupture of membranes for 60 hours and no antibiotics. So it's not difficult to understand why this baby was born with a rip-roaring infection and got pneumonia. And again, you know, to me, a baby born with a pneumonia who's been exposed to potential bacteria that obviously in this case was lethal, you're not going to leave that baby. And we certainly know that these parents, after this baby died, were about to instruct solicitors. I think they did instruct solicitors, and then it was all dropped when the police went knocking on the door and said, actually, we think this is about Lucy. But this baby is a clear case of medical negligence on the maternity side, in my head. You don't have a woman with ruptured membranes for 60 hours and don't give them antibiotics. And this baby also didn't get antibiotics for at least 4 hours. I mean, that was another negligent point. I think this baby was delivered and the father kept calling the midwife back saying, doesn't look right. And then he started grunting, did the baby. And eventually at 4 hours, they took the baby to the neonatal unit. But not only did they fail to give the mother antibiotics, but as soon as that baby was born, it should have had a full infection screen and started antibiotics straight away. But there was a delay of at least 4 hours.
Yeah, so I'll mention a couple of things. The first thing is that lots of nurses have obviously echoed what you've just said with regard to Child D. And I know a friend of mine who was a nurse, thinks that it's outrageous, essentially, that the parents haven't been compensated. It's harder for me to comment on that. I obviously accept other people's views and try to take them on board. I try not to comment myself too much about if I can cite an expert, I will, but I try not to talk about it too much from my perspective, because I've never been in a hospital and I've never had to give care or anything. So if I can cite the views of someone who knows, then I will, but I try not to comment myself. And then what's the other thing I wanted to say? Oh yeah, I can't remember now. It's not that important anyway. The most important thing. Oh yeah, I know what I was going to say. So we should mention as well. So you're talking about the parents are going to be compensated. The parents are going to take action and all this sort of thing. So we now have the email from Ian Pace, who was a lawyer associated with the hospital, and he's writing about Lucy's grievance procedure. And he tells the hospital the best case scenario we can have is for Lucy to do constructive dismissal, because we'll pay less money out that way. Yep. Otherwise, we face the prospect of being sued by parents, and that would be a less favourable outcome.
Michele also took some time with me to discuss some of the myriad of problems with the conviction of Lucy Letby in relation to child K.
So, speaking of not standing up to scrutiny, we're going to talk about child K and the extubations at some length now. So the first thing I want to ask you about is that in court, there was a lot made of Lucy standing over a baby, as it was described, whereas every indication I've been given is that this is just a normal practice of observation. So could you elaborate on that a bit?
So when an alarm goes off, those alarms are very intrusive. They're very loud, they're very shrill, and these are very vulnerable, delicate babies, including their hearing. So the first thing you do is you look at the screen, you hit what would be like a snooze button to silence it. And if you don't correct the problem within a given length of time, usually 60 seconds, the alarm will resound. So when they say that the alarm was switched off, that is not true. The alarm was silenced. And then, as a neonatal nurse, you stand there and you look through the perspex of the incubator and look at the baby. Because that alarm might be alarming for something as simple as the baby's wriggling and the probe's lost contact. Doesn't mean it's always because there's something going on. This baby, baby K, weighed 800 grams, I think. And these babies are very small. They're very vulnerable. Every time you open those incubator doors, you increase the risk of introducing infection to that baby. You increase the risk of actually dislodging a tube or a cannula or a line. So you never put your hands in that incubator until you've assessed what you think the problem is. So if Ravi had walked into nursery 1 and I'd have been there, I would have been stood there doing exactly the same thing, looking at this baby through the incubator before I ever put my hands in. And Ravi would know that. So I don't know why he's saying this about Lucy. He knows what neonatal nurses do. I think he just embellished his story to make it sound good, that she wasn't doing anything. And also, he's admitted her hands were not in the incubator. So how did she dislodge the ET tube? I mean, that's quite miraculous. Her hands were not on this baby. They were not in the incubator, yet he's saying she deliberately dislodged the endotracheal tube. He also, on the ITN documentary, said the 25-weeker can't dislodge their ET tube. And that is absolute rubbish, because babies wriggle, 25-week gestation babies wriggle. The tubes themselves are tied in via their bonnets. They're not what's called cuffed. So they can slip in and out of the trachea. These babies are very small. So I think baby K's tube was said to be 7.5 centimeters, which is maybe that long. So that baby only has to slightly move his head and move it a centimeter, and it's dislodged. Yeah. So I think Ravi just told a very good story that is definitely not based in fact. And as I say, if he'd have walked in on me, I would have been stood at the incubator appearing to not do anything. But it wasn't that I wasn't doing anything. I would have been assessing that baby. And I think that's exactly what Lucy did. And on the stand, she said that she was taught to do that in Liverpool Women's Hospital. But then you've got Elizabeth Morgan, who gave a statement to the court. Now, Elizabeth Morgan's an interesting character. She seems to have disappeared, but we've looked at as much information as we can from her. She's not pediatrically trained, and she's not a midwife. She's an adult nurse. She has undertaken apparently some neonatal training, but a long, long time ago. And she now works in management. And she's registered under South Wales. So is she a friend of Dowie? In her statement that was read out to the court, she contradicts herself, because part of the statement she actually says, yes, you assess the baby before you do anything. But then later on in the statement, she says, oh, you definitely wouldn't wait to see if a baby self-corrects a 25-week gestation baby. So which is it? That you stand there and you assess the baby, or you immediately intervene? Her statement contradicts it. But I don't think she's neonatally trained. I don't think she works clinically. From my understanding, she works in management. So again, she should not have been an expert witness talking about things when she doesn't work clinically, and she doesn't work in a neonatal unit.
And finally, Dr. Martyn Pitman, an obstetrician and gynecologist, has made several appearances on the channel. In the next clip, he discusses two of the triplets from the Lucy Letby case, namely Child O and Child P.
So that decision was made, and inexplicably, again, not a neonatologist, but I know enough about neonatal physiology to know that if you're going to stick anything sharp in a neonate's tummy, the one place you do not put it is in the no-go zone, which is on the right side of the baby's abdomen. And the reason for that is that you're worried about the liver. And the bits in the notes that report where this cannula was put denote McBurney's point, which is, if you were to go into casualty tonight with bellyache, Chris, and they were trying to work out if you've got an appendicitis, they press at somewhere called McBurney's point, which is it's an eponymous name given by a surgeon from hundreds of years ago. And that's basically near where your appendix sits, and it's sort of low down on the right-hand side of your tummy. But it's irrelevant in neonates. It's just not used as a terminology in neonates. But anyways, cannula is put in the right side of the baby's tummy, and there are reports that it wasn't greeted with a whoosh of gas coming out of the baby's tummy. It was greeted with aspiration of frank blood, which should have been a huge warning sign.
It seems like it seems like a fairly obvious warning sign.
Yeah, because it basically means either what you thought was gas in the baby's tummy actually wasn't. It's a collection of blood, or you skewered it into something where you don't want to go, as in the liver. So I don't understand that. The other thing to throw into the melting pot in this is that the individual, the consultant that did this, is clearly a trained sonographer, because the same individual scanned the baby's heart to rule out there being congenital heart disease. Now, the technicalities of doing that and looking at you're looking at a moving organ. I used to do it as part of my job, looking at a moving organ with complex connections. The technicalities of being able to do that are infinitesimally higher than being able to use the same bit of ultrasound kit, which was clearly available in the unit, to guide your insertion of a sharp object into that baby's tummy. And you would use the ultrasound, and it would be dead easy to tell that below the baby's skin, where you're about to stick your sharp object, is either gas, blood, or an organ. It would have been dead easy to tell. Why that consultant didn't use the ultrasound machine, which by definition was clearly there to guide his insertion of that sharp object, a cannula, is anybody's guess. I don't understand that at all as a sonographer. So what else do we know? Well, the other thing that we know, which I think that hasn't been covered at all as far as I can see, to clarify things, is what we do know is that 2 blood samples were taken during this resuscitation. One was taken at about 13:30, when the baby owes hemoglobin, so the amount of oxygen carrying capacity in the baby's blood was registered at 197. And then a second sample, which is the thorny issue, at 5:30 was taken when that hemoglobin had dropped, but hadn't just dropped; it had spectacularly dropped down to 86. So it had more than halved, which by anybody's standards is a catastrophic, is evidence of catastrophic, life-threatening blood loss. And that was documented by the consultant who undertook the paracentesis procedure in the notes. So what we have to question here is with this baby, think about the whole clinical picture. This baby's heart rate was persistently elevated, the concerns with breathing, concerns with developing acidosis. I suspect what was going on is that gradually this hematoma was developing, and then the crash of this baby was due to the hematoma bursting, forming what's called a hemoperitoneum. So you lose the tamponading, the pressure effect of the membrane around the liver. You get acute blood loss into the baby's tummy. And the only way you're going to rectify that is to give blood. Now, I don't understand how any experienced clinician, consultant can take a blood test from a neonate, see a hemoglobin of 86, compare that with the one only a few hours earlier, which was twice that level, and not then ask for a blood transfusion, because that's the only thing apart from surgery that's going to put this right. But that wasn't done for whatever reason. So that's my theory. And I think, if you think about what was going on at the time with the active resuscitation, so you're going to have somebody in between all of this pumping up and down on the baby's chest, are we really thinking that wouldn't be enough physical trauma to that poor baby's liver to cause what was found on the post-mortem? The other issue here, of course, and it is documented, is that even Dr. Bowen commented at one point that, in her view, when she looked at this case, she advised that further emphasis should be placed on the insertion of the cannula into this baby's abdomen. So even she was questioning how this was conducted, which I think is very pertinent.
It's telling, isn't it? I mean, I was really surprised when I saw that.
Yeah. Yeah, but I don't think it clearly didn't go anywhere. It clearly didn't go anywhere.
Let's not speculate on why.
No, absolutely. And of course, the other thing which concerns me about this is, and again, I saw this on one of the other forums, that there appears to be a missing document around the resuscitation time. Like it's been named as a document number, And on that document, apparently denotes exactly when the abdominal drain was put in and exactly when these blood test differences were recorded. Now, it's interesting because apparently Mike Hall reports never seeing that document. Now, one has to question if full and frank disclosure of the documents around these cases was undertaken, why the defence weren't given access to that critically important document, given the other issues about this case. And I want to get close to understanding that. So, a lot of information. There's a few other concerns. We discussed the ventilatory mismanagement. So if you inflate the lungs with too much pressure, you decrease the venous return that gets back to the heart, and you push the liver down. We discussed the lack of intravenous access in an unstable baby. This actually got worse because what you don't want in this situation is for an acutely shocked baby to then require you to urgently try and establish access, because that's incredibly difficult in these small babies. But what they did then was to insert what's called an intraosseous needle. This is a bit gory for the non-medical people, but if you can't get into a baby's vasculature, there are specific, what are called, and they're pretty brutal, because obviously you have to get through the baby's bone into the bone marrow. They're pretty brutal bits of kit. So you force this instrument into the baby's bone marrow, and you use that to give fluid. It was reported that they didn't have any of those on the neonatal unit, from my understanding. So they had to use what's called spinal needle, which is something that's used by anaesthetists. So again, you just wonder, well, what is going on in this neonatal unit? You don't even have the kit that you need in emergencies to do these procedures. So another red flag. Yeah. So we discussed availability of senior staff, the specialist registrar who was around, so the resident doctor who was around initially was called away to look after another baby. It took 40 minutes for a consultant to arrive. My understanding is I think that this was from the parents, that the first consultant who came was a few minutes later seen in the car park having a cigarette. How? I mean, I don't compute how that can fit. And then we come on to the, what happened after this poor baby died. And this is, I think, Steph Davis, her findings are critical in all of this. So, what happened with the coronial notification of this death? I understand that the coronial notification was completed by the anonymized consultant, not by the consultant that had done the invasive procedure on the baby. And inexplicably, given what I've uncovered, there was no mention at all that the cannula insertion into this baby's abdomen, the drop in hemoglobin, was mentioned to the coroner. Well, why? It was fundamentally critical. There's evidence from the Thirlwall inquiry that the coroner had communications with the department to say he couldn't find any evidence of mismanagement, but it appears that judgment was made without being given all of the clinical information. And from what I can ascertain, which I think is what Steph Davis picked up, was that the coroner was only notified about the insertion of the paracentesis cannula some 3 months after the baby's tragic death. So that's a concern. And then we move on to a document I've only recently seen, which is I think we're gonna screen share this, which is so I need to do that from my side, Chris. Yeah.
Yes. Again, we've rehearsed this, but please just bear with us a second. So yeah, just move your mouse around, and you should get. There we go.
Okay.
So this got successful.
Can you do that, Chris?
Just bear with us 1 second. Yeah, we can see now.
So this is a document that was released from the Thirlwall inquiry. So this is basically what's called a hot debrief, which happened immediately after the resuscitation. So we'll just go through this fairly rapidly. The first thing to notice, given the concerns that we've been discussing over the last hour or so, is this bit here, which is the grading of what had happened. So there was an acceptance by the people that took part in this meeting that there was suboptimal care, but the conclusion was that different management would have made no difference to the outcome, which I think in itself is somewhat questionable. And then I think the other things that are divulged in this document are gravely concerning, because it seems to me that the team that were present that formulated this document used almost deflection tactics, and that there was a focus on, there was a query about why intravenous antibiotics were given. So the reason for that was respiratory distress, and there was a conclusion that it probably wouldn't have made any difference. There was an issue about TPN, which is establishing feeding for the baby. And there was a question about point 3, no record of the registrar examination. It goes on. So there's relatively trivial things were volunteered on this. But then it gets even more interesting. So a bit about the nursing notes. And then we move on to point 5, where it says all radiographs to be, so these are x-rays, to be reviewed again. And this is fascinating, isn't it? In view of probable enlarged liver and importance of timings of films taken. So there appeared, bearing in mind that the consultant that presided over this meeting was the one who inserted the drain into the baby's abdomen, that there was already concern at this point about the baby's liver being enlarged and potentially pushed down. So, but that concern didn't extend to notifying the coroner about that, or the placement of the cannula initially. Then point 6, concern about the delivery. Consult with the obstetric team, and the possibility of a subcapsular hematoma being due to the actual delivery. So that may well be where shoe leads. So was the concern from the neonates in theatre about the nature of the delivery of the babies? I don't know. And then in a way focusing then on aspects of good practice and good team working, 3 consultants present for most of the resuscitation. So that there's enough in that hot debrief of this case to make me question about what was going through the team's mind about what had actually happened with this baby. So again, can't answer that, but there's enough things in there to make me concerned that this was almost deflecting away from what could have happened.
Yeah,
I won't go into that anymore, but I thought that's quite a significant finding.
Yeah.
So just before we go on to a far briefer discussion about baby P, in view of what I did with the other twins and now this one, I've got huge concerns about the safety of procedures that were being done in that unit. You know, we've got evidence from the previous twins about repeated failures of IV lines, particularly central lines, UVCs, and peripheral lines in babies, and delegation of that down, particularly with those babies with their prothrombotic tendency, that being delegated down to junior doctors, where you really want those to go in first time and get infusions running first time. We've got plentiful evidence of intubation problems, and that was very relevant to these babies as well. And I think the intubation of certainly baby O was undertaken by a pretty junior neonatologist. We'll move on in a few minutes to grave concerns about the recognition and treatment of pneumothoraces. And with all of that going on, one has to wonder about the standard of basic neonatal resuscitation that was present in that unit. If you're going to be deficient in basic procedures, then there has to be a question mark about the efficacy of the resuscitation. I think most pertinent to all of this is the parents' recording and reporting of what it was like in the neonatal unit when all of this was going on, and that's heartbreaking to listen to or to read. You know, they describe scenes of utter pandemonium, of chaos, you know, staff running around, of panic, and that's I can't compute how that can happen in the UK in the 21st century. and for parents to observe that and to be mindful of that when their babies are clearly suffering as a consequence of that is just beyond belief, really, in the NHS in the current era.
So that's a summary of some of the key evidence that experts have conveyed to me via my Lucy Letby analysis channel. That barely scratches the surface of the expert opinion that I've been fortunate enough to collate and the arguments against the conviction of Lucy Letby. In my forthcoming book, Reasonable Doubt, Examining the Case of Lucy Letby, I go into much more depth regarding the multitude of problems with this very obviously unsafe conviction, with this egregious miscarriage of justice. Reasonable Doubt will be released on the 9th of July in hardback, paperback, e-back and audiobook format.